Hi, welcome to the show. Hey, my guest today is Dr. Jeffrey Roth, and he's going to talk about the most interesting medical topic you can think about, your appearance, plastic surgery. You know, what is the difference? When people say plastic surgery, cosmetic surgery, is there a term of art, a difference in it?
Great question to ask. Basically, plastic surgery, plastic comes from the Greek plastikos, to mold or to form. So plastic surgery really has been around for about 2,500 years. There's been some ancient parchments and ancient writings that have been seen for millennium about doctors changing the shape of or the appearance of tissue. So plastic surgery really comes from plastic and reconstructive surgery. And as plastic surgeons, we do cleft lips and palates, we do burns, we do reconstruction, we do replant surgery for fingers, we do a whole lot of things. Cosmetic or aesthetic surgery is a subdivision, if you will, or one of those things that plastic and reconstructive surgeons do.
And how do you delineate when you would need to see a dermatologist compared to a cosmetic or plastic surgeon?
Great question to ask. Typically, we get made fun of all the time as plastic surgeons because we take care of the skin and its contents. Dermatologists basically concentrate on the skin, and in a perfect world, the plastic surgeon and the dermatologist work together. For example, I have a lot of dermatologist friends here in town, and there's some very good dermatologists and very good doctors here in town. If someone comes into my office and there's a lesion that may be suspicious or that I may not know what it is, I don't hesitate to get a dermatological consult. Typically, dermatologists are great for rashes, for skin cancers, for lesions of unknown origin, and that sort of thing. If dermatologists often will take something off in their office. They may do little flaps, little reconstructions, but oftentimes dermatologists will also refer to the plastic surgeon if it is in a funny area next to the eye or eyelid, if it's a large area on the face. And again, working together, we can try to cure the lesion, whatever it is, take the minimal amount of tissue, and then make it look as nice as possible.
Now it seems like even within your industry, you have specialists working on different body parts. I mean, there's now cosmetic surgeons or plastic. So what do I say, cosmetic or plastic?
That's right. Plastic surgery is fine. So okay. So that's fine. Okay. Yeah, there's the old joke that if your head cold moves into your chest, you have to change doctors. In plastic surgery, the field is so wide that oftentimes it's hard to get everywhere. Now, there are some guys, some professors that can do that. For example, cleft lips and palates typically go to the university surgeons where they have a cleft lip and palate team with pediatric orthodontia and pediatric anesthesia, and those places tend to get the best results. While in the community, yes, we do reconstructive, yes, we do aesthetic or cosmetic surgery as well. So here in Vegas, it's nice because it's not like some New York type outfits or Los Angeles, Beverly Hills type outfits where there's the nose man and all he does one day, every day is noses. Here in Las Vegas, we have some very good plastic surgeons, and most of them find their niches. Some are face folks, some are more body folks, some do all of that. And then most of us also stop doing the stuff that we'd rather not do. Again, stuff like cleft lips and palates typically go to the university, and then the non-university guys, let that go.
Right, and because the reason I ask is my daughter at one time had something on her eye, and I took her to the eye doctor and then to another ophthalmologist, and then he finally referred her to a doctor who does plastic surgery, but kind of specializes on doing things in and around the eye.
Yep.
And I know there's doctors that do liposuction or breasts. I mean, or else maybe they just have reputations for doing those.
Right.
Right. But I guess the rage right now is doing non-invasive cosmetic procedures, Juvederm, Botox, that type of thing. Maybe you can take me through what some of the differences are.
Sure. There is a tremendous amount of things coming out on the market now, non-invasive. And I had an old professor tell me once, he said, you know, Jeffrey, if you ever get bored in plastic surgery, you're not reading enough, because there's always something new. What you're referring to is, especially concentrating on the face, is stuff that we don't have to go to the operating room for. For the upper part of the face, we tend to like Botox for the area between the eyes, for the forehead, and for the crow's feet. The lower part of the face, we typically like to put volume in there, and there's many different chemicals or different attributes that we can put in there. For example, the classic is the nasolabial fold, which is this area right here. And what you want to do there is basically put some material, put some filler in there to try to take the valley and make it less of a valley, so you don't see the shadow quite as much in there. These things that we can use are the hyaluronic acids, which are your Juvederms and your Restylans, which you probably heard of. There are other compounds, which is like the Irradius, which is basically calcium hydroxyapatite, which basically think of it as liquid bone. We used to use that in reconstructive, where if somebody had a facial fracture and they had a little gap in the bone, we would squirt this stuff in, kind of like Bondo, if you will,
right, yeah.
put the face back over it, and it would smooth out. We also have another compound for larger areas of the face called Sculptra, which I've used a lot in the HIV population. As you know, they get very gaunt, and so we use that for larger areas in the face. What we've discovered as plastic surgeons is not to take out volume in the face, because back in the day, in the 70s and 80s, as you remember, we used to take out the fat pads. We used to, the dentist would pull teeth because everybody wanted to look like Twiggy. Everybody wanted that sunken in look. Nowadays, we found out that that's been a tremendous mistake, and now it's all about putting volume back into the face to try to get people a little more youthful appearance.
But the fillers and Botox work differently. I mean, they interact differently with the body, right? I mean,
absolutely.
Botox
Yep.
works with the. Why don't you explain how that works?
Absolutely.
Yeah.
Botox, and if you use them correctly, they can really work hand in hand. Botox, again, like for the upper part of the face, what that is, it's a chemical that you put in the muscles, and it stops the muscles from moving. When you do that, you typically will smooth out the wrinkle on top of that. Now, sometimes, especially in fellas, the wrinkle has been there for so long that you go ahead and do Botox as your first line of defense, but then you may have to come back and put a little filler in that pesky wrinkle. Lower half of the face, you tend to have a lot more muscles going in different directions, so it's hard to delineate exactly where to put the Botox in that particular muscle. So typically we would, again, volumize the face or try to caulk in the line, if you will, to try to take down the valley, and so it doesn't look quite as bad.
Did you ever think when you were going to medical school you'd be sitting here using terms as this? It sounds like you're almost, you know, working in my bathtub.
Well, yeah. So we talk about that in the office all the time. You know, we're the body shop. You know, you come in and we go ahead and work on that. And of course, occasionally gals with their breast augmentation devices may have a leak, and so the common joke we have is yes, we fix flats too. So
we'll get to that part of the body in a minute, but
sure.
One of the complaints I hear about Botox is that some women get a lot of Botox and it kind of changes their ability to use their face in expressing themselves.
Right. There is an artistry with anything, and that's why I really love plastic surgery, in as much as it's a real, in my opinion, a real marriage between art and science, where you take anatomy, you know the anatomy, and you have this tool, if you will, the Botox, and so, well, how am I going to use this tool to shape the face? Or, more often, not shape the face, because what you really want is somebody to look like them, but you want them to just look freshened up. And we've all seen, you know, people in the mall, and you go, oh my gosh, what happened to that girl? By and large, you really, you know, want to reach out to them and say, you know, come to a guy that really sort of knows the anatomy, knows the artistry, as well as the science. You don't want to make somebody look not like themselves. You don't want to have someone change the shape of their mouth or the shape of their eyes or the shape of anything. You basically want to have them, but freshened up.
Don't we see ourselves differently? Because it seems to me that people who you can look at and you can say, well, that person's had too much work done. And they see themselves as not probably having enough work done.
Absolutely. There's always a time where you have to take the punch bowl away at the party. And that's why, in my opinion, you go to a board-certified plastic surgeon, somebody who can not only cut and sew, because at this level you really should be able to cut and sew, but you're going for a consult and say, well, doc, I want to go from A to B. And the doctor should be able to tell you, well, we can't go to B, we may be able to go to B minus. Or what's the best way to go from A to B with the least amount of invasiveness? And sometimes you just can't do it. There is such a thing as body dysmorphic disorder, and we are always on the lookout for that. And those are those folks that whatever you do to them, they're still not going to be satisfied. They're going to look in the mirror and see themselves as ugly, and they may very well be distraught about that. So in plastic surgery, believe it or not, you start to be a bit of a psychiatrist, and I always sit and I talk to patients for a while as to what their goals are. Why are they kind of doing the operation? It's not just, you know, being a hairdresser, and I love my hairdressers, don't get me wrong, I'm not making disparaging remarks, but when you get into somebody who's going to go to surgery and have a permanent fix, it's a little different.
Yeah. The Juvederm and the Restylane and the filler things, they have a lifespan, right? They last, what, 6 months, a year?
Yes, depending on what you put in, the hyaluronic acids, like we talked about, typically have a lifespan of 6 months to a year. Around the mouth, they tend to break down a little bit faster because people talk and chew and that sort of thing. The Radius, they say, will last about 2 years, and the Sculptra, depending on who you ask, may last a year, 2 years, or get some collagen ingrowth. What I want to warn people away from is permanent fillers in the face. Silicone, as you know, is illegal to inject here in Nevada, and I think that that's a really good law because we see people from out of state that come in here, and you have to try to correct the silicone. Our faces,
it moves, or?
Yes, our faces change with time, and so as we get older, we lose soft tissue in the face, your face sort of slides down, and we actually know now that the bone tends to recede in the face. Okay, so the last thing, in my opinion, that you want is something that's stuck in the soft tissue layers of the skin that's permanent, and we unfortunately have had to dig out more silicone than you can shake a stick at. So it's, again, a choice of what the patient's goal is, what the proper filler should be, and everybody always wants to come in and say, well, you know, geez, doc, I had this filler, it was great. Is there anything more permanent? And the answer is yes, there is, but there is a line where you have to say, all right, you don't want it to be completely permanent. You do want it to fade away at some point.
And how safe are the temporary fillers?
I think that they're very safe, in as much as I put them in my family, and that's another litmus test that I have. If I have something in the office, I'm going to be able to say that I would do this for my family member or my girlfriend or my father or whatever. And if I'm not going to go ahead and put it in them, I'm not going to put it in my patient. So having said that, is me, I'm a big conservative by nature. I'm data driven, so I want to make sure that this is safe and effective. For me, anything we do in the office, it has to be, number one, safe, and it has to be effective. If you come in the office and you want something and I'm not your guy or I don't think it's going to be effective, I'll tell you that. I'll say, you know, this isn't going to work.
For a number of years, the most popular procedure in Las Vegas was breast augmentation. Is that still the case? I mean, you walk around town, it's almost like, who doesn't have it, right?
That's right, yeah. Any given night at the Hard Rock, you know, so you would think 90% of the gals around there have that. Las Vegas has always been a big breast augmentation town, both in number, in volume of how many we do per capita, and also volume as in how many cc's. It usually rounds out in the top five being Los Angeles, New York, Las Vegas, Dallas, Miami. And we're usually in the top 3, and we're usually in the top 1 per capita. So.
And what is the conventional wisdom now with saline implants and silicone implants?
Sure. Well, I think that they're both very good implants, and I think that they have both of their pluses and minuses. Silicones are a gel, so they feel a little bit softer. So if how things feel are important, I would push more towards a silicone. Also, if somebody has a rippling issue, you tend to have less rippling with the silicone. Now, anything can ripple, but you tend to have less. The salines, also a very good implant. They're a little firmer to touch. And the price point on them is a little bit smaller. So again, it really kind of depends on the gal, what she's looking for, et cetera, et cetera. We do about half and half in the office.
For a while, silicone was the prevalent type, and then the FDA came in and they were removed from the market and they were using saline, and then the FDA allowed silicone back under certain circumstances. Now are this condition still in place, or is it now the science advanced and the doctor just chooses one or the other?
Right. Well, back in '92 and '93, when there was the big silicone controversy and the FDA pulled them off the market, now they only pulled them for aesthetic or cosmetic use. They were still available for reconstructive use. And silicone only went away in the United States and Canada, never went away in South America or Europe, et cetera, et cetera. What they found is even those silicone implants, the Institute of Medicine study and 400 peer-reviewed studies have all shown that there was no cause between silicone and all of the neoadjuvant diseases that were supposed to go on. Okay, having said that, the new and improved silicones that are out there now, and things get better with age. Cars get better with seat belts and airbags, et cetera, et cetera. Having said that, is the new silicones with the leak rate, which is much, much smaller than it ever has been. With the Gummy Bear implants, basically all those restrictions have gone off. The restrictions that they do have on silicone are basically two. One is the FDA wants you to get an MRI every 2 to 3 years just to make sure they're not leaking, because they want data as to what the actual leak rate is. And you know, you go up to an FDA board and you have to give a couple of compromises to go ahead and get things through. And that actually was a pretty good compromise, so that we can actually see what the real leak data is. The other compromise, if you will, that they made is you, by federal regulation, should not or cannot put a silicone implant in somebody who's under 22 years old. So that was another thing, which is probably not a bad law as far as that goes.
But you can still do the saline?
Yes. Salines, federal regulation says that you have to be 18 for saline, 22 for silicone. Unless, again, you have a reconstructive option if somebody comes in with one side is tremendously larger or smaller than the other, that sort of thing.
And how long do the implants last?
Implants are not permanent devices, so the party line is basically most folks will be looking at one more operation during their lifetime.
Is the second operation more difficult, removing the old implant? I assume as scar tissue forms and you have adhesions and things like that going on.
Sure. Typically, it really depends on the patient. For example, we do those sort of things all the time as the patients age and they come in for removal and replaces. Often people will come in also for salines to silicones. It depends on what's been going on with their breasts. Most folks, if they're nice and soft and everything is doing well, et cetera, most people won't even change them out. If they're not leaking and they're soft and everybody's happy, typically people leave them alone. That pendulum really has swung. Now, if there's leaks or if there's problems or that sort of thing, well, you have to address those issues. And those may be the trickier parts of it, especially if you have to go ahead and cut through a little bit of scar or that sort of thing.
Yeah. And what is the choice that one has to make, like over the muscle, under the muscle, that type of thing?
Great. So that's another technical choice that you take a look at the patient and see what their goal is. Typically, 9 out of 10 plastic surgeons now will go underneath the muscle for a first-time breast augmentation for 3 reasons. One is I think it looks more natural because you're putting more soft tissue between the implant and the outside world. 2 is you tend to have less capsular contracture, less capsular scarring, and also 3, they tend to stay put longer. Back in the day, as you know, we plastic surgeons in the 70s would put very large implants, especially here in Vegas, on top of the muscle, and sometimes we would see the implant kind of slide down the chest wall. That really kind of has gone away with the advent of most guys putting them underneath the muscle. Now, having said that, There are still some indications to put them above the muscle, just depending on the patient's form, what her goals are, etc. But most of the guys, most of the time, like to put them underneath the muscle if they can.
And of course, liposuction. Lipo, what is it?
Well, liposuction,
okay.
sure.
Liposuction has changed also. And isn't that becoming a little bit less invasive, or taking less fat out, or different places? What's the state of the art of that now?
Absolutely. There's really been kind of a revolution in liposuction over the last 20 years. Back in the day, we would make our incisions, we would take these cannulas and try to suck out fat. And that really was painful. You had bruising, etc. Nowadays, the modern temnescent liposuction technique is one there you go ahead and you put in a little bit of fluid before you start sucking out. And what I mean by fluid is it's the same fluid that you would have in the IV. It's lactated ringers or normal saline, with a little bit of lidocaine, which cuts down on the pain, and a little bit of epinephrine, which cuts down on bruising. And with that, you're able to infiltrate the area, see where you're going, and then you take the cannula and you suck out the temnescent solution along with the fat. The cannulas have changed over the years too. Now they used to just be sticks, if you will. Now some of them vibrate, some of them rotate, some of them have ultrasound on the tips of them, some of them have lasers on the tip of them, and this is all part of the big flux that's going on in plastic surgery right now. And again, you have to fit the tool for that particular patient. For example, ultrasound liposuction was all the rage probably about 5 or 6 years ago. And there's upsides and downsides to everything. I like the ultrasounded liposuction for really tough fat. And by tough fat, I mean mostly fellas, and mostly fellas with gynecomastia, or guys that are HIV guys that have what they call a buffalo hump, which is between their shoulder blades. Now we see less and less of that as the HIV medicines have gotten better. But before, these poor guys would come in with this kind of hump between their shoulder blade, and we would liposuction it out. And I tell you, that was kind of tough stuff to get through. With the advent of the ultrasound, that made things a lot nicer.
And the lasers, that's also, you know,
that's all the rage.
Another tool in the box, right?
Yeah, that's all the rage. And laser's always sexy, and it always gets a lot of press. But again, you have to be very careful with it. Most of the laser companies will go ahead and tell you that it's not for 5 liters of liposuction, the big liposuction. It may be very good for areas that are more difficult around the knees, around the ankles. But again, you have to be very cautious, because the laser, you know, can burn on the inside, and we've seen that in general surgery, and now we are seeing a little bit of that in plastic surgery. Like anything else, you have to see the patient, you have to do your history, your physical, and then whoever is wielding the knife or the laser or the ultrasound, whatever it is, has to know what they're doing, where they're going. And in my opinion, it was really beaten to me as a surgical resident, if you can't take care of the complication, don't do the case. So in my opinion, it's important to recognize what can go right, what might go wrong, and then avoid that as well.
You also work with boxers.
I do.
You work with the Boxing Commission. In the old days, you know, you see the boxer, you know, get cut, somebody get a pound of hamburger meat and stick it on his face, and you know, obviously that's a terrible thing to do. As far as you can get infections as well from that.
Right.
But what are some tips on you know, for parents? You know, your child falls down, hits her face on something, and it starts to bleed. You know, what's the first thing you should do?
Absolutely. No, I've been privileged to work with Bob Arum's Top Rank Boxing, and they do a terrific job. And I'm there after the Athletic Commission guys do it, and they do a terrific job. They're specially trained, and after they make their evaluation and the patient boxer is not going to go to the hospital, if there's a cut, well then yes, I'll go ahead and step in. For moms and dads out there, a couple of things that we see often in the pediatric population, and again, this is off plastic surgery, but please buy a thermometer, because oftentimes people have fevers, et cetera, and one of the first things that pediatricians will ask is, well, you know, what's the temperature, and you know, we don't have one in the house. Getting back to plastic surgery management, anything that gets cut on the head is going to bleed a lot. So the first thing is, don't panic. And kids are going to fall down, and kids are going to have their you know, a couple head bonks and all that sort of thing. So the first thing is Kid's going to be yelling, screaming. You know that. That's a baseline. Second is elevate the head, okay? And second is if you can, try to put some pressure on it and cold. Ice is always good. So ice, elevation, always good stuff. And then if you can, try to take a peek, see if there's any foreign body, glass, gravel, et cetera, and if you can, displace it or wash it out, great. If not, always okay to go to your local pediatrician, your urgent care, or your emergency room, because these guys see that all day long. And basically, during one's lifetime, especially if you have boys, you're going to be in the emergency room 2 or 3 times getting sewn up. I tell the story. This little scar I have here, I'm a long-term Las Vegas guy, and I was water skiing on the lake. And I think I was 16 years old and fell, and so I had to go ahead and get stitches in the old DeLima campus. And I go through my medical school, I go through all of this training, et cetera, et cetera. I have all these letters after my name now. And sure enough, I get called down to sew up guys in the emergency room at DeLima. So it took a long time to get from one side of the gurney to the other side of the gurney. But it was kind of neat.
Circle of life.
Yeah.
So once you have the scar, is vitamin E, or what do you do to minimize the permanent scarring?
Sure. Well, first of all, scars are permanent things, and scars can be unpredictable. They can be thick or not thick. They can be red or not red. Typically, scars look worse at about 4 months, and then better again at about 10 months. Right. Now, having said that, good things for scars are protein, being a healthy person, not being on a diet that consists of saltines, okay? Protein is important. Non-smoking, tremendously important for scarring. For example, myself and most of the plastic surgeons in town won't do facelifts on smokers, because 99% of the people that have had a problem with their facelift, as far as wound healing goes, have been smokers. Now, as far as scar healing goes, one is to actually look at the wound, keep the wound cleaned, keep the wound not on tension, and that all tends to help.
And we're running out of time, so
okay. So
don't put ice. Don't put ice on it. I know that, right?
So that's okay. Well, you ice first, and then no. Ice is good things for
scars, but not for burns.
So burns is okay too. You want cold and ice on burns. So ice is always good stuff. And then towards the end, then you go ahead and have salves and creams.
Thank you, Dr. Roth. Hey, we had a bunch of other topics we could have talked about. If you want to have any questions, please contact our website, or we'll link you to Dr. Roth's website. See you next week.
Be sure to visit us online for more information about today's guests, to see past shows, or even contact us about being on the show. Simply go to theedbernsteinshow.com. That's theedbernsteinshow.com.